I'd like to introduce our next speaker, Professor Rod Mitchell. He's professor at developmental endocrinology at the Queen's Medical Research Institute in Edinburgh. His main research interests include developing regenerative medicine technologies for pediatric cancer survivors with testes, and understanding the germ cell niche and the origins of testicular cancer, and understanding fetal gonadal development. He has several external awards from the UK Research and Innovation and the Wellcome Fund. Some of Professor Mitchell's recent research investigates extracellular vesicles on urological malignancies or developing sperm. It's my pleasure to introduce him to welcome him to the podium today.
Thank you very much, Monica, for the introduction, and thank you for the organizers for inviting me to come and speak. It's an absolute delight to be back speaking in front of real-life people and real audiences, so that's fantastic. And the other thing I'd like to say is the first conference I've ever been to where the host has invited every attendee to his house for dinner. So that is a new one for me. Thanks for your hospitality last night, Kyle. So I'm going to talk about preservation and protection of fertility, and I'm going to switch from what most of the talks have been about so far from females into males. So you'll all be aware of this concept that if you were diagnosed with cancer as a child back in the 1950s or 60s, the likelihood is you would die as a result of your disease, whereas now we're faced with the fantastic recent results that patients are likely to survive over the long term. But it gives us the issue of the long-term follow-up of these patients and a large number of patients who are facing problems directly related to their treatment. And so for boys, of course, they're no exception, and fertility is a particular issue for boys facing treatment. And for these boys, the option of collecting sperm for fertility preservation is not there, and therefore we're always relying on the idea of preserving the somatogonia within the testis. So what happens to somatogonia with treatment? So here's just an example of a study looking at testicular biopsies from individuals with a variety of different conditions. And you can see in the gray circles and the gray shaded area, this is the normal number of somatogonia in the testis. But if you focus your attention on the black boxes in the bottom, these are individuals who've been exposed to alkylating agents. And what you can see from this study is that these somatogonia numbers are drastically reduced and in many cases completely lost as a result of alkylating exposure. So we know for sure that these boys are at risk of infertility. What can we do for patients? Well, at the moment, the main focus is really on trying to preserve their potential, preserve the tissue that has the somatogonia in by taking a testicular biopsy from the patient before their treatment and freezing that tissue. What would we then do with the tissue beyond? Well, as you know, the idea is that we can potentially put either the tissue or the cells back into the patient to restore their fertility, or alternatively use in vitro type approaches. And Ellen Goossens will talk about using transplant technologies to restore fertility in patients. But of course, this is quite a laborious process to go through. It requires surgery at both ends of the process, and it's not without its complications and challenges. So is there an alternative way that we can approach this? And one way in which we can potentially think about this is to try and protect the gonad from the damage. Before we go there, I want to talk about the work that we are conducting at the moment, looking at preserving potential in these patients. And so what we're really talking about for preservation is to take testicular tissue from the patient, so to perform a biopsy, and here you can see a typical wedge biopsy performed, the testis is taken out, wedge biopsy is performed, the tissue is then sewn back up and put back into the scrotum. And that tissue can then be taken to the lab, can be processed, can be cut into fragments, and can be placed into cryomedia in either vials or in cryostraws. And that can be stored for as long as the patient might potentially need it. So in this endeavor, we have established a similar kind of program in Edinburgh back in 2015. It's a program where we can store clinical tissues from patients. We can store the tissue for up to 55 years, and that's for their sole use in the future. But we're also able to do some research with a small portion of that testicular tissue, and that really allows us to use it to develop strategies not only to restore fertility, but also to try and understand how we might be able to protect their fertility. And this program is active in the UK. We have 2 centres in the UK, Edinburgh and Oxford, who are both the coordinating centres. And patients can have their biopsies taken from a variety of different areas within the UK and transported through to the coordinating centre. And up until the present day, we have just over 500 patients who've had testicular tissue biopsies taken. In fact, if you look around the world at the centres that are taking testicular biopsies, you'll see that we now really have built up a very large cohort of patients from whom testicular tissue has been taken. This is data from the ORCID-NET Consortium, which is recently set up with 13 centres who are currently offering testicular tissue cryopreservation. And we've conducted quite a large-scale study to look at what's being offered to patients at present. And this was talked about yesterday. Some of you will have seen the much more comprehensive data in the committee meeting yesterday. For anyone who's undertaking testicular tissue cryopreservation programs who haven't been able to be involved in the ORCID-NET Consortium so far, I'm happy to hear from you as we go on. So what we've talked about really so far is what most of the research is really focusing on, and that's preserving the tissue and preserving the potential, and then using it to restore fertility at a later date. But really what we're interested in our group is actually looking at alternative ways of preserving fertility. And in this case, we're talking about preventing the damage. Now, to prevent the damage, you really need to understand better how the damage is occurring. And for that, you need appropriate models to make that judgment. And so that's what I'll focus on the next few slides, on how we can understand the damage and how we can actually model this in a human-relevant and clinically relevant way. So for these studies that I'm going to talk about going forward, we've really focused very much on one group of chemotherapy agents. We've focused on the platinum-based chemotherapy agents. And that's based on 2 reasons, really. The first is that the platinum-based chemotherapy agents are used in a variety of cancers, childhood cancers, particularly several of the solid tumor types. The platinum agents that are used are cisplatin, which is the original platinum agent and most commonly used agent, but carboplatin has subsequently been introduced as a result of its reported lower side effect profile. I'll talk a little bit about that as we go on. What we realized was when you look at the studies that involve assessing the impacts of platinum-based chemotherapy in childhood, there's really relatively limited data. There's clinical data out there, but quite a lot of that, it's difficult to really unpick the specific contribution of cisplatin to that damage. And what there isn't any up until relatively recently are experimental studies that allow you to actually understand the effects of platinum-based chemotherapy and use that as a model for testing chemoprotective agents, fertoprotective agents. So we started off looking at this by looking at an in vitro mouse culture system. This is prepubertal mouse testis, cultured for 4 days and for 24 hours of that period exposed to cisplatin. And what you can see here is that the germ cell number is drastically reduced across a range of doses which are clinically relevant in terms of their concentration. And so you can see that the cisplatin is clearly causing damage and loss of these germ cells in the mouse testis. But how do you test this in the human? Can you actually do studies that involve a more physiological and clinically relevant approach? And so for this, we've developed a model system of hanging drop culture, which involves using human fetal testis tissue. And the reason we use the human fetal testis is it has germ cell populations that are representative of the variety of germ cell populations that you'll see in fetal life, infancy, and through to childhood. And you can see there some of the markers that these different germ cell populations will express. So the hanging drop really allows us to maintain the tissue in a good state in terms of architecture, histology, cell populations, and also function, hormone production, etc. It's a very nice representative model of human testis development. So when you use this human fetal testis culture and you expose the tissue to cisplatin, here you can see an exposure for 3 days, you can see again the significant reduction in the germ cell number as a result of exposure to cisplatin. You can go one step further and you can take these cultured tissues that have been exposed to cisplatin and you can look to see what the long-term effects of that treatment might be by xenografting those tissue pieces into a host mouse. So this is tissue that's been xenografted, having already been exposed for grafted for a further 12 weeks, and then you can see that still this germ cell loss is persisting over a prolonged period of time. If you then start to look at these cultures and compare different drugs, here you can see an example of comparing cisplatin with the other platinum agent, carboplatin. And whilst we're all familiar with the concept that carboplatin has a lower side effect profile in terms of other body systems, certainly from this culture model, we don't see any specific difference in the germ cell loss that occurs with cisplatin exposure compared to carboplatin exposure. And again, these are both in the clinically relevant dose range. What about the somatic cells of the testis, so the Sertoli cells being the primary supporter of germ cell development? Well, when we look at these Sertoli cells in these cultured testes exposed to cisplatin, we see no change in the number of Sertoli cells, we see no change in the number of apoptotic Sertoli cells, and when we measure the hormones in the culture, so AMH and inhibin B as two key Sertoli cell hormones, these are again unchanged by exposure to cisplatin. So it looks like the effect is really very much primarily on the germ cells of this cisplatin exposure. So of course what I've showed you so far is all using the human fetal testis, and I will take the point of anyone who says, yes, but you're still not talking about the appropriate tissue for clinical relevance. So we've also been able to now do some studies where we culture the tissue with cisplatin, but we use human prepubertal tissue, so we use the relevant tissue in this context. And so these are taken from biopsies from patients. This is some of the tissue that's been donated for research. And when you expose to cisplatin, what you see is there's a significant reduction in the number of somatogonia, similar to what we found with both the human fetal testis and the mouse. But if we use a marker which is representative of the somatogonial stem cells, so UTF1, we actually see that there's a significant reduction in also the subpopulation of cells which appear to represent the somatogonial stem cells. And what you can see from that somatogonial stem cell graph is that there is a complete loss of somatogonial stem cells for 2 of those patients for whom we exposed the tissue to cisplatin. So our expectation for those patients would be in vivo exposure to this dose of cisplatin might be expected to wipe out their somatogonial stem cells and render them infertile. So we've talked about understanding the damage. The next question is really, can we use these models? Can we use these approaches to look at ways in which we can prevent the damage from occurring in the first place? And you will be familiar with the literature on some of the potential fertoprotective agents, and we saw some of them mentioned in the talk on the female, and some of these also have been thought to apply to the male. So you can see here a list of agents that have been tried as fertoprotective agents in rodents with differing degrees of success. So the question is, would any of these potential fertoprotective agents be applicable to the human situation? And we became mostly interested in GCSF as a potential fertoprotective, and that's really because we know that GCSF is used already clinically for patients to mobilize their stem cells and to treat neutropenia, and used already in cancer patients. So it might be a drug that is not unfamiliar to this particular population. And support for the idea that GCSF might be a fertoprotective agent comes from some of the rodent studies that have been performed by Brian Herman's lab, where they showed using a variety of different exposure regimens, so exposure before, during, or after the chemotherapy treatment, in this case busulfan treatment, that there was some degree of restoration of somatogenesis in these mice when they were given GCSF in combination with the chemotherapy agent. So this gave us the opportunity to use the models that we developed using the human tissue to try and see whether GCSF is also protective in this context. So we performed very similar studies to those that the Herman lab had performed, but this time we used cisplatin again as our model chemotherapy agent. And we exposed these human fetal testes to cisplatin with or without different doses of GCSF. And you can see here the regimen that I'll show you just now. And so when you look at the effect of the cisplatin alone on the germ cells themselves, then you can see, as we expect from the previous studies that I've shown you, there is this reduction in germ cell number as a result of cisplatin exposure. And of course, what you want to see next is I'm going to click this clicker and you're going to see some amazing restoration of germ cells and potentially of fertility, but you know what's coming, because actually, in this case and in this study, we don't see any protection of GCSF on these germ cells. And that really, I think, is an important lesson for us to be ensuring that when we're doing these studies, particularly the rodent studies, that we're able to try somehow to translate those to how they would appear in the human situation. We've also done another couple of regimens, so not just over the whole period of treatment, but some before, some after, and still we don't yet see any effect of GCSF on these germ cell numbers. So what about an alternative approach? Rather than taking the candidate approach or trying to pick our agents from those that have been found to be successful in rodents, should we use a more unbiased approach in trying to identify fertoprotective agents? And so for this, we've developed a drug screening approach to try and pick out agents that we think might be protective that we can then take on into our human tissue models. And so for this initial drug screen, we've used a somatogonial cell line, we've used a GC6 SPG cell line, we've exposed those cells to cisplatin, and we've also used 1,280 different FDA-approved drugs and small molecules as a test for their fertoprotectivity. And the important thing is that these are all drugs that are commonly used in clinical practice at present, so that obviously if we identify one which is potentially protective, it's likely to be much quicker to be in clinical practice in the future than newly identified molecules or signaling pathways. So we've optimized this system to be able to allow us to look at the difference between cisplatin-exposed cells and control cells. And that means that we'll be able to identify whether the different agents that are used as potential fertoprotective agents are indeed fertoprotective. This is the way that the system is set up, so you can see the well plates with the controls and cisplatin in the first columns, and then the test compounds across all the rest of the wells. So it's a large scale, or relatively large scale approach. When we do this screening, what we find is that each of these lines you can see on this graph is an individual drug and whether it's protective or not. And we use a threshold of what's called a Z-score to try and determine which ones are hits in our screen. So you can see there's a few peaks there peaking up above the threshold line, and each of these drugs is considered a hit on the initial screen. So far we've done the screen. We've been able to identify a number of different compounds that are potentially protective for these somatogonial cells, some of which you will recognize, especially the clinicians amongst you will recognize many of these drugs. And so we're in the process now of validating these hits, and ultimately, once we've validated the hits, we want to take these obviously into our human fetal tissue system to really try and determine just how relevant these are to a clinical situation. So I hope that I've given you some kind of a feel for the importance of preserving fertility in young males. an idea of some of the things that we might be able to do to restore fertility, but importantly to try and protect fertility in males. I also want to, or hope I've given you the concept that the in vitro approaches and the xenograft approaches are potentially useful ways of actually determining the effects of cancer treatment and the impact of potential protectants in a more human-relevant system. And we think that the drug screening approach is likely to identify and has already identified some very promising targets for chemoprotection or fertoprotection that we are now going to go on to validate in the human testis tissue models. So with that, I will say thank you, acknowledge the most important people, the people that have done the majority of the work, so members of my group, close collaborators locally, members of the ORCID-NET Consortium, and the funders that funded the work that we do. And I'd like to thank you very much for your attention and looking forward to your questions. So thank you.
Hi, Rod. Thanks for sharing your wonderful work. It's exciting to see what you'll find next. I wanted to ask a question about one of your early slides, and I know this wasn't the focus of your talk, but you showed some effect on the testes and sickle cell. And I was curious if your group is doing any work in this area. You know, we know that when kids with sickle cell get bone marrow transplants, they're at high risk for future infertility, but there's more research now showing concerns about the disease itself and newer drugs like hydroxyurea, which are being used in younger and younger kids. And I just was curious, number one, if you're doing any work in this area, and number two, what your thoughts are.
Yeah, so it's a good question, Lena. So we are not ourselves in our group doing work with sickle cell, but there are quite a number of groups within the sort of European consortium that we have who are focusing very much on sickle cell. And I think probably the summary is that it does appear that there is already underlying damage in individuals with sickle cell in terms of fertility. What the contribution of hydroxyurea to that or not is not quite so clear, but it does raise the question, if the individuals with sickle cell already have impaired fertility before you're even considering doing a biopsy, then you have to think about what it is you're preserving and what the potential for that tissue is going forward. So I think the sickle cell group is quite an important group. But as you saw there, in the data, there are reduced somatogonia numbers in sickle cell patients generally.
Okay, thanks.
Thank you for the great talk. I just wanted to ask you about dissection of sperm from testicular tissue. And, you know, when we do that, we disaggregate the tissue, but we save everything. Do you have any recommendations around that, I guess? So we're choosing to do that for peripubertal boys.
So you mean how you cut the tissue up into the fragments and when, or?
Well, in terms of prediction, so I mean, we've looked at a little bit of data on prediction of sperm in testicular tissue in boys, but I guess, you know, whether it's really an appropriate thing to do considering the gain, you know, is it worth looking for sperm in young peripubertal boys?
Okay, so I think for that question, I think if you have a patient where there's the potential for sperm in that testis and you're doing a testicular biopsy, I think it's, I would recommend that you have a system to be able to extract sperm from that biopsy, and that's because you know that there's sperm, you know that sperm is the ultimate, currently the ultimate way that you're going to get fertility. It's proven clinically, etc., to work. So I think if you were not doing that and storing the tissue that contains sperm, you may potentially have lost a really major opportunity when we don't yet have a clinical option for tissue that contains somatogonia. Having said that, it's not an easy thing to do, to set up in terms of logistics, facilities, etc., and it can be difficult, but if you can do it, if there's sperm in the testes, you should try and get them.
I think our youngest was close to 11 years of age who had some sperm identified, but just, you know, 5 sperm. So I guess weighing up the balance of, destroying the architecture of the tissue to find that sperm versus saving the integrity of that tissue.
Yeah, I mean, I see what you mean there. I think then you've got to balance the probabilities. So in a 4 or 5 mil testis, you're not going to go searching around and mashing the whole tissue up to try and find sperm. In an 8, 10, 12 mil testis, you're probably going to put more effort into that. You can also obviously look at testicular volume, pubertal staging, etc. You can actually get some indication as to whether or not there might be sperm in there from clinical assessment of the patient beforehand. It won't be ideal, but it will give you an idea.
Thank you for a wonderful talk. It was great. It was just so well presented. Thank you. My question is, when you got your hits from the library, mechanistically, it was a really broad group of agents. Mechanistically, how do you think that they might function as protectants?
Yeah, we don't know, and at this stage we've just got a list of drugs, and they are very diverse list of drugs. So the first step is to validate them, and I think those that don't meet validation, we won't be looking into great detail in. Once we've completed the validation, then we might start to focus a bit more on the mechanisms. And of course, we might identify drugs that are protective. That would be great. But even if that drug doesn't end up, it might actually indicate the kind of mechanisms and signaling pathways that we should be looking at and look at other targets. So that's all still to be done.